as well as atypical forms of conjunctivitis, and how this, and there will be also a clinical case scenario which will be highlighting upon the cases which have been misdiagnosed or overdiagnosed on conjunctivitis. So conjunctivitis is probably one of the most popular eye pathology which an ophthalmologist as well as other doctors know, but still at times it gets misdiagnosed or overdiagnosed. So the next session will be taking you to a few clinical aspects, various presentations, as well as theoretical aspects of few cases of conjunctivitis. So the first talk will be taken by Dr. Sonal. She'll be highlighting salient points and cases about epidemic keratoconjunctivitis and highlighting features about adenoviral and microsporidial differences.
Yeah, so good morning everyone. We welcome you all in this course of conjunctivitis, and as Dr. Mayank was telling, this is the most common situation which we usually deal in our routine practice, but sometimes we really get confused whether it's infective, it's allergic, or it's any other thing which is actually mimicking like the conjunctivitis. So through this course we are actually going to try and clear up all the diagnostic dilemma, and for which we have a eminent cornea person with us. Dr. Mashkati and Dr. Rajesh Sinha, they are going to join us within a few minutes. Myself, Dr. Sonal Vyas, I am from SBH Eye Hospital, Raipur. I will be taking a talk on the epidemic keratoconjunctivitis. And then Dr. Mayank Mahajan, who is working as a phaco and refractive surgeon in Agra Center for Sight, and he will discuss a few interesting case scenarios. And we have a panel discussion also where we'll discuss about the few atypical cases. So basically, I'm going to discuss about the epidemic keratoconjunctivitis, which is also called as a red eye syndrome. It can be seen anywhere in the world. It can affect a large number of individuals, mostly infectious, mostly seasonal, and most of the time we think it's because of adenovirus species. So this is the clinical picture, which most commonly comes in our mind when we say epidemic keratoconjunctivitis. But in last few years, you must have observed that so many patients are coming with a similar symptom, mainly in the rainy season with the history of exposure to mud or rain. And the clinical picture is like this. So most of the time, we get confused whether it's an adenoviral or what it is. So when you will investigate, you will find that this is not the adenoviral, this is the microsporidial keratoconjunctivitis. So basically, in today's my talk, my main objective is to discuss about the adenoviral keratoconjunctivitis and to discuss about this new emerging pathogen, which is the microsporidia. So let's start with the adenoviral conjunctivitis, which is responsible for the 75% of all cases of conjunctivitis. Basically, it manifests in the two forms, Pharyngoconjunctival fever and the epidemic keratoconjunctivitis. As the name suggests, Pharyngoconjunctival fever is characterized by fever, pharyngitis, rhinitis, follicular conjunctivitis, preauricular lymphadenopathy, usually starts from one eye, then involves the other eye. The basic difference in both these entities like epidemic keratoconjunctivitis is that it involves whole of the ocular surface. So not only the conjunctiva, the cornea is also involved. And it is associated with the two most common complications. One is the pseudomembrane or the true membrane formation, and second one is the formation of subepithelial infiltrate. This is the pathognomic feature of adenoviral. And when you will make a slit beam, you will see the deposition, which is actually an immunological reaction against the virus antigen, and they are deposited in the anterior stromal layers below the epithelium. The diagnosis is all the time made based on the clinical feature. Patient comes with the typical feature of mild pain, photophobia, foreign body sensation. And if you want to confirm, the cell culture and PCR can be done, but they will take time to give you the results. Recently, rapid antigen detecting kits are available, but I think cost will be an important concern with these. So now there are a few situations which can mimic like a viral conjunctivitis. So we'll discuss them one by one. The bacterial conjunctivitis, you will find the matted eyelashes, mucopurulent discharge. If you are in a doubt, you can send the conjunctival swab to confirm it. Allergic conjunctivitis, the most common feature will be the itching, while the itching will be less common in adenoviral. And as in adenoviral conjunctivitis, we see the follicular reaction, but in allergy, you will find there will be the papillary reaction. The patient will give a history of allergy, And the disease will start simultaneously in both eyes. While as I said in adenoviral, one eye is involved first, then the other eye. Toxic conjunctivitis, the most common symptom will be irritation and the burning. There will be angry looking red eyes, and follicular reaction will be there, and there will be a history of chronic use of eye drops. Other viral conjunctivitis like herpes and molluscum can also mimic, but in these cases you will find the typical lid lesions. Chlamydial conjunctivitis will be having a subacute or the chronic course. The follicles will be larger in size, and maybe there will be a history of some genitourinary infection also. So now coming to the management part, as per the preferred practice pattern from American Academy of Ophthalmology, the disease has a self-limiting course, and we don't have any specific antiviral drugs for this disease. The disease is infectious for 2 to 3 weeks. So our main aim is to provide the symptomatic relief to the patient, to control the infection, shorten the duration, and the complication management. So symptomatic relief can be provided with the help of artificial tear, cold compression, and in topical antihistaminics if required. Antibacterial drugs have, there is no role of antibacterial drugs in adenoviral conjunctivitis. Second thing is we have to control the infection. As it is a highly infectious, so as an ophthalmologist, it's our duty to inform the patient that it can spread to anyone. We have to explain the patients to maintain the personal hygiene. Even in hospital also, we have to clean the instrument properly if we saw these type of cases. Next important thing is, as I said, it's a highly infectious, and the infectious period is around 2 to 3 weeks. We need to shorten the duration. So for which various drugs have been tried like gencyclovir, pseudofovir, but none of these drugs are found to be that effective. Recently, povidone iodine is showing a good result in these cases, and ongoing research is basically on the povidone iodine in different concentration. Next one is the complication management. As I said, there are two most common complications: membrane formation and the subepithelial infiltrate. So if you find any membrane which look like this, you have to remove it, because if you leave them as such, they are going to do the cicatrization and the sympliferon can be formed. If it is an early membrane, you can remove it with the sponge, but sometimes you may need forceps to remove this membrane. Second is subepithelial infiltrate. So these are the two complications where we are going to use the topical steroid eye drops. Otherwise, the role of topical steroid is always controversial in adenoviral conjunctivitis. So the two important situation is pseudomembrane, we have to remove it, we have to use a steroid. Second is subepithelial infiltrate, and very carefully use the steroid, because it has been shown in the animal models that the viral replication and the viral shedding has been increased if you are going to use the steroid. And so it means it prolongs the viral persistence, and even in cases of subepithelial infiltrate, when you stop the steroid eye drops, you find that there is a recurrence also. So to prevent these recurrence and to prevent the steroid-dependent these side effects, nowadays cyclosporine and the Dalimus drugs are used. And we are also finding a very good result with the cyclosporine eye drop, especially in the cases where the recurrence is common. So to summarize, for adenoviral, it is highly contagious, has a long incubation and the infectious period. We don't have any gold standard testing or treatment, and which is making the adenoviral conjunctivitis a significant global economic burden. Now coming to the next part of my talk, that is the microsporidal keratoconjunctivitis, which I said is an emerging ocular pathogen. Initially, it was thought that it is a disease of immunocompromised, but now we have lots of studies where it shows that it can affect the healthy individual also. Even one of the report from LV Prasad Bhubaneswar, where they have done a study on the 300 patients, and they found that the association of microsporidia with epidemic keratoconjunctivitis was significantly higher than adenoviral. That means what we are treating as adenoviral were actually microsporidia. This is the typical clinical picture of microsporidia keratoconjunctivitis. The magnified picture, you can see discrete, wide, raised epithelial lesions are there, in contrast to adenoviral, where the lesions are subepithelial. The diagnosis in these cases are confirmed with the help of microbiological examination. Most commonly, Gram and the KOH with colcofluor white stains are used. Other stains are also there. It's very easy to diagnose. You can easily see the spores in the smear. But again, we don't have any specific antimicrosporidial drug. Whatever drugs have been tried in the literature, albendazole, itraconazole, even the PHMB drugs, they doesn't offer any significant advantage over the placebo, which shows that it is a self-limiting disease. So these are few patients where we tried the corneal debridement along with the lubricating eye drops, and we found a very good results. So to summarize, in microsporidial keratoconjunctivitis, it is actually underdiagnosed, most commonly misdiagnosed as adenoviral keratoconjunctivitis. We need a very simple microbiological evaluation to do, and the treatment outcome is very satisfactory. Thank you. So I think we have Dr. Muscati is here. Dr. Muscati doesn't need any introduction. He's a very famous cornea person from Mumbai, and he's known for his own style of making any session interesting. So for the next talk, I would request Dr. Muscati. Is there any question? We can take the question while he is adjusting the laptop. Sorry, sir? Specific treatment. So basically, we do the corneal debridement, and if you are suspecting there's secondary infection, you can use the antibacterial drugs and or the lubricating. Because all the studies have shown where they have tried the placebo, the lubricating, and the various drugs, but the results were similar in both the series. The most important thing is to avoid the steroid in these cases. Most of the cases we see in our clinic that it was considered as an adenoviral subepithelial infiltrate, and we start the steroid and they flare up like anything. So that's the most important thing to differentiate it, the location of the infiltrate. Yes, sir? Yeah, in the Orissa and these types, it is very common. During rainy season, even the our state, Chhattisgarh, it comes like in a one day, 7 to 8 patients of microsporidia is coming. Yeah. The two studies have been done. In one, povidone iodine 0.4%, and in one, 1% was used 4 times a day. But the data is not that sufficient, so we need and the trials are undergoing of 0.6%. But that is the only drug which we can trust in the future. It has shown a very good effect both on the free parasite basically. Yeah. Yeah, so initial, yeah.
See, what happens, as she correctly said, avoid steroids. You don't have to remove those lesions. Let those remain. It will be a slit lamp finding for you. The important thing is that is the patient comfortable or not comfortable. So patients are fairly comfortable. Those angry white become softer white, grayish white with time. And as long as they're not in the pupillary area, you might see 20 of them, but they don't disturb vision. Leave them there. You don't have to eradicate it with steroid. So I put the patient on topical cyclosporin 2% and the tacrolimus ointment at night, cyclosporin in the morning, along with lubricants for 6 months at a stretch. No harm at all. Unlike steroids, which you use only short term in pulses, this can be used for 6 months at a stretch with no problem. It sometimes takes a year, 2 years for it to go away. But it is annoying to you as the surgeon, not annoying to the patient. So leave it there. As far as povidone iodine is concerned, I do use povidone iodine much, and it's not that microsporidiasis is more in the south. It is reported from the south. It is because what the eye doesn't know, what the mind doesn't know, the eye doesn't see. Many years back, I discovered something called conjunctivochalasis, where they lead in dry eye. Till 5 years ago, I thought there was no conjunctivochalasis, no such entity. When I learned about it and I started seeing my patients and just pushing the lower lid, I found those ridges. And now I'm seeing conjunctivochalasis because I learned what it is. So similarly, microsporidiasis, many times we dismiss or think it is part of adenovirus. If it is a stuck-on appearance, it is microsporidiasis. If it's under the epithelium, it is adenovirus. Treatment remains the same in the sense that you can use povidone iodine and you can use lubricants. And both of these are self-limiting conditions. You need to avoid steroids. In microsporidiasis, it just disappears. In adenovirus, you might use long-term tacrolimus or tacrolimus. Yes, but many times, every time you stop the steroid, it jumps up again. It becomes angry looking again. While with tacrolimus, it never becomes angry again. It just slowly fades or may remain for a year or so, but it doesn't disturb the patient. So lubricants continue for 6 months and tacrolimus continue for 6 months. Same, I use povidone iodine in all my cases. I do a scrape. The microsporiditis is on the surface, so it's easy to scrape. Scrape, bandage contact lens, and povidone iodine drops with lubricant.
Won't it affect the contact lens?
How does it matter? In 2 weeks, I'm throwing it away. So in 2 weeks, let that contact lens be damaged. I'm not reusing it, throw it away. So 2 weeks is sufficient for treatment. Adenovirus takes longer time.
Even the epithelium is so loose, when you will just give a nick in case of microsporidia, it will come off very easily.
Yeah.
So even if you are doing like routinely sending the samples for the gram staining or any staining so it become a routine practice. Just to scrape it, it will come off very easily.
Debridement is not only for examination, for diagnosis, but also for treatment.
Both diagnostic and therapeutic. Yeah.
Exactly,
Yeah.
exactly. You can scrape with anything. It comes off fairly easily. I use a Bart Parker 15, but you can use even an iris repositor.
Just a nick and it will slough off.
Dilute it till it becomes less burning. It is still effective. So I take the povidone iodine and dilute it 1:5. And the commercially available Septidine, I dilute 1:5 sometimes. It is still effective. Don't use Paracane because it reduces symptoms. You'll never know when the patient gets a fulminating bacterial infection. He won't come back to you with symptoms or fungus. Sorry. You can use, as long as it's tolerated well by the patient, even 2-hourly povidone can be used. This is a little technical talk on allergic conjunctivitis because I was asked to speak on basics and current understanding. So allergic conjunctivitis is actually a group of diseases affecting the ocular surface and is usually associated with type 1 hypersensitivity. There are 2 acute disorders called seasonal allergic conjunctivitis and perennial allergic conjunctivitis, SAC and PAC. These are 98%. And there are 3 chronic diseases, vernal keratoconjunctivitis, atopic keratoconjunctivitis, and GPC. So the whole umbrella of allergic conjunctivitis is actually about 5 diseases in one. There is some differentiation between them. So SAC and PAC incidence varies markedly with geographical regions. So Italy, Japan, other warm climates report more of these. Histamine is the primary contributor to the development of early phase signs and symptoms of SAC, usually in distinct waves that reflect allergen exposure. For example, in the US, when the pollen rises up tremendously, you get more of the SAC. On the radio, they announce that today the pollen count is so much. So patients who have got asthma and patients who are suffering from SAC stay indoors on those days. VKC and AKC are chronic allergic diseases that originate from more complex mechanisms than SAC. Here, eosinophils, resident conjunctival fibroblasts and epithelial cells, mast cells, Th2 lymphocytes, all of these take effect. So it's a more complex etiology, and histamine deficiency exists with VKC. Male to female is 3:1, affects kids and young adults. There is specific IgE type 1 and non-specific type 4. So you get type 1 and type 4, while the other was only type 1. Here, if you do tier IgE levels, they are increased. They can be measured by microassay. Specific IgE is found in 60% of cases, while 40% are IgE negative. There is increased conjunctival B cells, and these are some of the trigger factors which are found. They're discovering more and more trigger factors, including even simple things like free radicals. So perhaps there is some role of giving long-term antioxidant pills. Atopic keratoconjunctivitis occurs more frequently in men aged 30 to 50 years, and there is a family history of allergies, asthma, urticaria, and others. Typically in Japan, they found that atopic dermatitis or eczema starts in childhood, and the ocular symptoms develop later on. And the primary symptom of AKC is intense bilateral itching of the lid skin, so everything itches around the eye. In AKC, because it's such a sort of virulent disease, there is chronic cicatrization changes, severe corneal disease, high risk of infections, and these are the patients with eyelid rubbing so much that keratoconus tends to develop in almost 35% in some studies. And in Japan, the AKC, even the ocular manifestation occurs at an earlier age. In other European studies, they found that the systemic manifestations come in childhood, but the ocular manifestations come later. So the surface inflammation is mast cell driven. In the acute phase, there is itching, tearing, lid and conjunctival edema, and a classic late phase response is there in a subset of individuals. And some can also develop a chronic disease and the whole surface gets remodeled. So again, now let's look at this. There is a type, what is a type 1 hypersensitivity response? There is an airborne allergen. Suppose it is say pollen, which is, we call that the antigen. Antigen combines with the IgE antibodies. These are circulating antibodies which are membrane bound. These attach to receptors on the mast cells. That Y shape that you see is the receptor attaching to the mast cell. When it presses on the mast cell, you have a pointer? So this is the Y-shaped receptor. This is the dust mite which is there, which is one of the allergens over there. So these Y-shaped receptors sit on top of the mast cell. This Y shape is composed of the antigen with the antibody complex. They dabao this mast cell, they press on this mast cell. Now this mast cell has got these granules inside. So when you press on the mast cell, it releases the granules. This is an artist impression of the mast cell with the granules being released. So it causes what is called degranulation, this receptor binding with the antigens. Now these granules are released. In the granules are certain mediators. So those mediators get released into the ocular surface. What are the mediators? Tryptase, heparin. The most powerful is histamine. So these get released into the extracellular matrix. This starts a cascade of biochemical events leading to the formation of new mediators, which are prostaglandins and leukotrienes. So again, to repeat, first the pollen, that an allergen comes, it binds with IgE, it forms that Y-shaped thing, it dabaos the mast cell releases the granules release very powerful mediators like histamine. Now these in turn cause secondary mediators to be released, which are leukotrienes and prostaglandins. Now these then attack the blood vessels and they cause leakage of the blood vessels, because they release what is called chemokines. Chemo is drugs or proteins which are attracted, and they cause influx of inflammatory cells. Now the blood vessels are leaking inflammatory cells into the conjunctival mucosa. So that's how you get an inflammatory response. In shield ulcers, this is a different pathology. There is a mechanical irritation to the corneal epithelium. These giant papillae cause mechanical irritation, and you get toxicity occurring over there. It's a severe form of VKC, and it needs treatment by a different mechanism. Unless you remove that shield from the ulcer, it's not going to heal. So thank you so much. So this was in essence the pathology of the basic understanding of what goes on in the eye. Type 1, type 4 is there, but mainly it is a type 1 hypersensitivity response. Thank you.
Thank you, sir, for the wonderful talk. And now Dr. Rajesh Sinha is with us. So Dr. Rajesh Sinha is Professor of Ophthalmology in RP Center, AIMS, and I would like to thank him because he agreed to take this talk at that on the last moment request. So thank you, sir. And he's going to discuss about the Werner keratoconjunctivitis and its management. Meanwhile, if there is any question regarding allergic conjunctivitis. I would request Dr. Muscati, sir, to please join the dais.
There are allergy tests. There are allergy tests of two types. One is called the skin prick test, and the other is a blood test. So you take the blood and screen it for different allergens, or you do a skin prick test. We have 84 allergens. We have 160 allergens. Different skin prick tests are there. I use this in patients who have got atopic disease. That means they have an allergic asthma, they have an allergic eczema, and they have allergic eye disease. So if they have more than one thing, then the mother is more prone to allowing the child to be pricked or to get blood tested for this. Because after this, you can identify, it's a little expensive, you can identify the allergen. Once you identify the allergen, then there are either sublingual or intramuscular injections of that allergen in homeopathic doses, gradually increasing. So you build up the child's immunity. It does work very well, but it takes about 3 months for these multiple injections. They have to follow up with you every time. So again, it's useful in those who have got 2 out of 3 at least of the allergic. Just for allergic eye disease, I don't use it because our other treatment like mast cell stabilizers and others work fairly well.
The only issue which I feel, and many of us have felt, that there's so many allergens, and an individual who is sensitive to one allergen may be sensitive with many more allergens. So that is a concern.
So that's why when you do this allergy testing, it gives you strongly positive, mild positive. So you can do it, you can give these injections with 1 or more allergens. It's not only one allergen.
I will request Dr. Muscati sir to please come and join here.
Very good morning to all of you, and I'm extremely thankful to Dr. Sonal for including me in this course. I'll be talking about vernal keratoconjunctivitis. We have been using this terminology very often in our day-to-day practice. In our day-to-day practice. And now the point is that basically what I mean here by vernal keratoconjunctivitis is a chronic bilateral seasonal allergic inflammatory disease of eye involving the tarsal and bulbar conjunctiva. So basically it is an allergic eye disease which is seen in children specifically. Recurrences are common, and vernal means related to spring, related to a season. But it's actually not directly related to a season. It mostly, nearly half of it is almost perennial, and it gets exacerbated during the season. So that is something which we all understand, and that's how we take care of these patients, these children. So these are basically school-age going children, 4 to 7 years of age, and mostly we all explain to the parents that, it's there and you have to take care of it. And by puberty, it will, fizzle out, it will reduce, or it will go off. That is thing. Male children, it has been found in literature, is that males are more commonly affected. However, there are many female children as well who have this thing. More often, it is a child who is having some other allergy. Like if somebody comes to you with this VKC, it's always better to ask about systemic allergy, whether the child sneezes a lot, whether the child develops cold very often. So these factors are very important. And there is a geographic predilection, like in the Africa, Middle East, Japan, India, South America. In these places, we have a lot of children who develop these allergies, this vernal keratoconjunctivitis. So, as I said, there is a geographic location. So, environmental factors are there which play a major role, which is here. Do you have a point? Yes, it's here. So, along with the immunologic factor, which is a type 1 immune reaction, the environmental factors play a role, and the allergens and the family history is all important. So as I said, that it is mostly throughout the year, but it gets exacerbated during seasons and during the spring season, and that is how they present. Mostly symptoms, these children, they complain of itching, photophobia, mucoid discharge, early morning stickiness, watering, redness, foreign body sensation. All these things are there. And what happens, what is the common thing that happens that parents say that, we have gone to many doctors and they have started the treatment, it starts responding, and then there is a tendency to leave the medication, they stop the medication by themselves, and again there's a rebound. So a waxing waning course is something which is consistent with these conditions. On examination, you get these papillary hyperplasia. You word the lid, and you see there's papillary hyperplasia. The typical cobblestone appearance with a giant papillae, so that is a very serious thing. And these cobblestoning, as when I entered inside, Dr. Muscati was talking about the mechanical irritation causing shield ulcer. So these cobblestoning, this causes mechanical rubbing onto the cornea, and that results in the shield ulcer. Then you have the Horner Tranter spots, pseudogerontoxin, which are the lipid lines, Maxwell leoncyne, in which there's pseudomembrane formation. Then there is superficial corneal neovascularization. Why? Because of the limbal stem cell deficiency that can be seen in these cases, and because of the inflammation as well, and increased pigmentation of interpalpebral conjunctiva, which is again a complaint of many of the parents. They say that the conjunctiva is the white part of the eye has some grayishness, some pigment is there. Why it is happening? And it is very often seen in VKC patients. It is mostly classified into bulbar VKC and palpebral VKC. In most of the cases, you have a mixed variety. For grading of severity, there are various grading that have been put forward. One is Bonini grading, and the other one is Gokhale grading. As far as investigation is concerned, as you all were asking right now, immunological tests, whether we should do it or not, it does help. However, the management remains the same in majority of the cases. So that's the reason why most of the clinicians, they don't do immunological tests. And even with people who take care of systemic allergies, they say that if there is a particular allergen with which one individual is sensitive, then he may be sensitive with many more allergens. So you have to keep, testing with many allergens, and then finally again you have to give the treatment almost remains the same. You have to take care of the inflammation. So that's why many of the ophthalmologists, many of the physicians, they have stopped doing immunological tests. What is most important in these cases is not only to treat the patient, treat the symptoms, and but also to take care of the complications of VKC. And because of the constant eye rubbing, secondary keratoconus is something which is very often seen. Then we should, for that you should do a corneal topography, and Fourier domain ASOCT will give you the earliest sign of corneal ectasia. When you don't get any sign in pentacam, and a child is having allergy, and the child is rubbing the eye repeatedly, you should definitely do the epithelial thickness mapping by Fourier domain OCT. And if there is thinning in the inferior, inferonasal, inferotemporal part of the cornea, thinning of the epithelium, then that is slightly suggestive of occurrence of the earliest keratoconus. So these are some of the complications that one should rule out, one should look for actually. Like as I mentioned, keratoconus, then limbal stem cell deficiency is very often seen in these cases. You can have corneal scarring, shield ulcers here. Then you can have steroid-induced cataract and glaucoma. That is very important. Ptosis can be seen because of the giant papillae, and that is something which has to be ruled out. And symptoms like dry eye, it is the symptoms of itching is primarily because of the VKC. But after that, what happens when there is a little bit of the inflammation of the surface causing some blockade of these ducts and some loss of goblet cells, in that case the retention of the tear film on the ocular surface starts reducing. And because of these drugs that we use also, that also causes surface toxicity, and that results in dry eye. So it is a vicious cycle, and we have to be very careful, and we have to be very judicious in our management, which I'll be discussing now. What is most important is a good parent counseling. Patient counseling is also important if the child is 10, 12, 13 years of age, because you have to convince the child that the drops have to be put properly. Pharmacologic therapy and surgical therapy are the options. Now, coming to pharmacologic therapy, the drugs that we have often used earlier was topical antihistamines and mast cell stabilizers. These are the ones that we have been using for years. Now, of late, we have got these dual-acting agents, and they have taken care of the inflammation not only by blocking the histamine receptors, but also by preventing the release of these inflammatory mediators. So that's why dual-acting agents like olopatadine, ketotifen, and currently bupropion also is being marketed with good results. So all these drugs are useful, and they help in improving the outcome. And the advantage of dual-acting agents is that the child doesn't like to put too many drops. So it works well. You just put a dual-acting agent here and another lubricant, and maybe you can add something more depending upon the severity. Now, cyclosporin is one drug on which I have a lot of trust as far as the ocular surface is concerned. We have done a couple of studies. It is an immunomodulator. So we did a couple of studies on prevention of corneal graft rejection. It doesn't work. But it has effect on the ocular surface, and that is for sure. So, and you can use it on long-term basis. We have done a study. We have found out that 2% cyclosporin given 4 times a day has a concentration of less than 150 nanogram per ml, and anything beyond that only will have a systemic toxicity. So it is very safe, and if you are using for ocular surface, the concentration is quite low. You can use 0.05% or 0.1%, both depending upon the severity. This use of cyclosporin should be done on a long-term basis because the effect starts taking only after 6 to 8 weeks. So the effect starts after that. Till that period, you have to take care by use of steroids, by use of other medications. Tacrolimus is another good drug which can be used, and it is used as an ointment. So you put it in the night time, so the whole night there is a layer of tacrolimus, so that is quite useful. As I mentioned, topical steroid is very, very essential. However, we have to be really careful when we are giving steroid. We can give topical low potency steroid, we can give a high potency steroid for a very short burst, depending upon the severity. If it's very severe, in that case, high potency steroid can be given for maybe a couple of weeks, and then you can switch over to the low potency steroid, and then continue on a long-term basis. But then you have to taper it off. What is most important here is that tapering of steroid should be done very carefully and very judiciously. So given a choice, if I have a case of a VKC wherein the giant papillae, in that case, I will start, if the patient is very symptomatic, maybe initial burst I'll give 1 week or 10 days of a high potency steroid to get the symptoms controlled. Then I will switch over to the low potency steroid with the same frequency, and then gradually taper it off. Say if I have started dexamethasone, I won't give prednisolone in these cases. I will give a dexamethasone. Why? Because prednisolone and dexamethasone have similar potency when we are using it in any inflammatory eye, like in say for cataract surgery. If we are using, they have similar potency. But dexamethasone is a stronger steroid. Prednisolone is not as strong, but the penetration of prednisolone is greater than dexamethasone. That's why intraocular effect is same. But we want surface effect. So I will give dexamethasone. I will not give difluprednate because there are ample evidences now that it causes, even in a short-term basis, many times the patient develops glaucoma. So for a VKC, no point giving such a potent steroid. But if it's very severe, for a week or 10 days, I may give dexamethasone maybe 4 times a day, and then immediately switch over to fluorometholone 4 times a day. If it's a moderate severe, I won't put this high potency steroid. I will immediately go for a fluorometholone. And after fluorometholone, it has better surface action than loteprednol. So I will give fluorometholone, and then later on switch over to loteprednol. So the reason is why you have to juggle with all these, that you don't want a complication. You don't want steroid-induced glaucoma, and you don't want steroid-induced cataract. That is very important. However, steroid is such an important drug that you have to give in many of these cases. Supratarsal injection of steroid is given when you have a cobblestoning. and you have to give it. There's no option. And initially, you start. You put the patient on topical steroid, and when you see that it is not responding, then in that case you have to give a supratarsal injection of triamcinolone acetonide, 0.5 to 1 ml. It's a 40 milligram per ml vial, so 20 milligram or 40 milligram can be given. So first, and mind you, one injection will never help, will not help in getting relief of such a cobblestone. On an average, if I'm giving, I usually give 3 injections. This is the average that I give. I may have to give more, but then you have to be really careful. So the first injection should not be more than 0.5 ml. See whether the response is there or not, and see whether there's any complication or not. And such patients, if you are giving supratarsal steroid, then such patients have to be followed very meticulously, because you are putting a depot, and the risk of glaucoma is high. So you have to weigh the risk-benefit ratio. That is important. And excision of the giant papillae has also been reported to be having good results. However, there can be recurrences. And personally, I avoid doing these excisions because there is the risk of symblophron formation. You have to put amniotic membrane, and then further there's some risk of recurrence as well as symblophron, and all those things are there. So personally, I'm not very convinced with shave excision, but there are people who do excision of these papillae. Shield ulcer is another thing, as I was mentioning, as Dr. Quresh was also telling, because of the mechanical rubbing, you can have a shield ulcer, and you can have a plaque like this over the shield ulcer. So if it is the case, then it is not going to respond. So what you have to do is that you have to remove the plaque and then put an amniotic membrane over it. Now, if after removing the plaque you have a deep gutter, then you put multi-layered amniotic membrane, 2 layer to fill the gutter, and then put an amniotic membrane inlay over onlay, onlay over inlay, so kind of thing. But here the gutter is not very deep, so this is one of the cases. The video has been given by one of my registrars. Mostly they only go and give the injections, even the supratarsal steroid. But then this is what we advocate, and this is what we do. So in this case, 1 layer of amniotic membrane is being put, and it helps in epithelialization. Not only in that, but we also it also helps in preventing the mechanical damage. So when we are doing this, along with that, we also give supratarsal steroid. And currently, this is a slightly old video. Currently, if given a choice in this case, I will ask my resident to put 1 layer of amniotic membrane here, and then put a layer here, stick it with fibrin glue, put a bandage contact lens over it. And that is really going to work very well for the patient. Sometimes, if you are putting a bandage contact lens, that hurts the patient. So you have to call the patient immediately on the 2nd day, whether it is hurting. If it's really hurting, then the patient will not accept it. Then you will have to remove that BCL. But many of the times it works well. So it's nothing is absolute. You have to titrate your treatment depending upon the patient's requirements as well as the patient's tolerance. So I would summarize by saying that this is a disorder. VKC is a disorder when you require a combination therapy of all these drugs. Now, steroid is a mainstay initially to take care of the inflammation. But later on, cyclosporin is one drug which can be used for a year or maybe 2 years, and it works very well because it takes care of the surface inflammation, as well as it doesn't cause any complication locally in the eye as well as systemically. Tapering should be done very carefully in steroid. If you are putting it 4 times a day, reduce it to 3, then reduce to 2, then put it once a day, then put on alternate days. So you have to be a very slow tapering of steroid, otherwise rebound is very commonly seen in these cases. Lubricant should be given along with these. I forgot to mention that. Along with the steroid and all these lubricants, they have both the effects. They wash off the antigen as well as they they provide the soothing effect, so the patient is symptomatically better. And you have to take care of the complications. You have to prevent complications that can happen because of VKC, like keratoconus, because of constant rubbing, and from treatment like cataract and glaucoma. So you have to monitor the patient, and a good parent counseling is very, very important in order to have a good response of the drug in these patients. Thank you very much.
Thank you, sir. Thank you for the excellent talk. I think you have covered the management part, everything you have covered it beautifully. So is there any queries from the audience?
Yeah.
So how many years together it can be continued? One thing. Second thing, have you ever combined cyclosporine with tacrolimus?
Yes. If it's very severe, it is always advisable to use tacrolimus along with cyclosporine. As I mentioned, the tacrolimus, you can put the ointment nighttime and it will remain for the whole night there. So it is very useful, particularly in those cobblestoning, no? You have to combine all these things. Otherwise, the child will keep on rubbing, and he will invariably develop limbal stem cell deficiency as well as keratoconus. So you have to be very, very aggressive in treating these patients. And you can't ask the child to put 1 hourly steroid or 2 hourly steroid. There will be severe complications. So you have to combine. That's why the first word in my summary slide was a combination therapy. Tacrolimus is a very good drug. It works wonderfully. So many times I have to combine tacrolimus with cyclosporine. The only issue is that tacrolimus, using it on a very long-term basis, because it is oil-based ointment, it can have surface toxicity also. So, but cyclosporine is something which can be used on a very long-term basis, 2 years, 3 years. It not only takes care of the surface inflammation, but it also improves the ocular surface. It also improves the goblet cell density. So the dry eye that can happen because of allergic conjunctivitis or VKCs, that can also be prevented to some extent by use of cyclosporine. That's why I say that I'm personally, honestly, very much impressed with cyclosporine. The only thing is that disappointment occurs with cyclosporine only when we expect it to work within a month or 2 months or 3 months. Use it without thinking anything, and see after 6 months there will be a huge difference. So first line of treatment for all these VKCs is steroid. I mean, inflammation can be taken care of by steroid only, but steroid has its own problems. So we need alternatives. So we have to start cyclosporine along with steroid because the effect starts only after 8 weeks. For the first 2 months, you won't have any response from cyclosporine. It definitely, I mean, 0.05 or even the lower potency drugs. So dexamethasone is something, the molecule per se has a risk of, causing high IOP or complication related to steroid. So if we are using dexamethasone, let's use it full potency 0.1% for a week or 10 days, switch over to a lower potency drug which has a lower tendency to increase IOP or to cause cataract, so that we feel relatively safe. And then obviously we have to supplement the treatment with nighttime tacrolimus and twice a day cyclosporine. And of course lubricants are also important. Sir? How long, sir, there is no guideline depending upon the severity. So if the patient is symptomatically better and he's feeling good, then maybe in 4 or 5 months we can stop it and continue on cyclosporine, lubricants, and maybe once a day fluorometholone or loteprednol.
So what should be the frequency of cyclosporine and lubricants?
So Sir, cyclosporine should be used twice a day, morning, evening. Lubricants can be used 4 times a day. So it has both the effects. It washes off the antigen as well as it gives symptomatic relief. It should be, I mean, obviously there should be a gap between the drops, but it should be given in combination.
So many patients are coming infected
Yeah. Yeah. Uh-huh. Uh-huh. Infection, you mean to say what? I mean, no, ropey discharge can be seen even in these cases.
Or maybe they
Okay.
wanted to know the
So,
super infection or.
yeah, so in that case, you can give, see, any conjunctival infection like bacterial conjunctivitis, which is happening. So, in such a case, you can give a short duration, I mean, for 3 to 4 days, you can give antibiotic drops and it goes off. It doesn't remain like that for very long. And if you have a patient who has a shield ulcer, again the treatment remains the same. Along with that, you can put an amniotic membrane. The third thing is that there is a possibility of this shield ulcer getting infected secondarily. So that is an option. That is the tricky situation. As far as conjunctivitis is concerned, that's not tricky at all. So such a situation is definitely tricky. In that case, when you have a ulcer which is becoming large and there is quite a discharge and you can see that it appears like a bacterial, you've got a proof by scraping and all that. In that case, first you have to treat the bacterial keratitis, and then only you can take care of the allergic element. And in such cases, you can't use amniotic membrane also or anything, because amniotic membrane as such has growth factors, and it is a double-edged sword. When there's an infection, if you put an amniotic membrane, it will flare up quite significantly. So first you have to treat bacterial keratitis, but these are extremely rare situations. Most of the times you get an ulcer which is shield ulcer, and if you invert the lid, you see this giant papillae and there is an ulcer. That is a shield ulcer, and you have to treat accordingly. You have to treat the allergy as well as do what I had shown. You can put amniotic membrane in.
And I think in doubt, scraping or microbiological evaluation can also help, whether if you are confused in a shield ulcer.
Yeah, absolutely. That will help. Apart from that, in a shield ulcer, the eye doesn't look that. It's not that angry looking eye. So it is not like that. But yes, if you have doubt that whether there's any infection or not, scraping should be done. And when you're doing scraping, one thing I have always told my residents also, that the first scraping you just throw away, because that is the slough tissue. So don't use that. You first scrape it off, remove it, and then take from the periphery and the base, and then send it. And you can immediately do a smear and have an idea whether there is any infective element or not.
How much should be minimal interval between the two subtarsal steroid injections?
Sorry?
How much should be the minimal interval between two subtarsal injections of the steroids?
See, when you are giving a supratarsal injection, you always wait for the effect for 3 to 4 weeks time. Okay, so you see whether the effect is there or not. 3 to 4 weeks. You first call the patient on day one. If you are not able to call the patient on day one, no issues. Call the patient after 2 weeks, because you want to see whether there's any problem or not. And then after that, we follow up weekly. At 4 weeks time, you see that there are still large papillae. At 4 weeks, you can repeat it. And then again, you follow up for another 4 to 6 weeks. Then after that, you can increase the duration, maybe 6 weeks. Because, see, basically you have to titrate your treatment. So initial good response, patient is quite symptomatic, less symptomatic. Then you can, put it after maybe 6 weeks time. So this is how you titrate.
Regarding cyclosporine, sir, there is a MNC cyclosporine multinational company, and there are currently so many local Indian cyclosporine. Do you find any difference between the two cyclosporine?
See, it's a little controversial thing, but to tell you frankly, with no financial interest, I have felt that the international company has low stinging when you use it. The Indian companies, when you put cyclosporine, there is a little bit of stinging sensation that the patient complains. But with the international company, that stinging sensation is still there in 1 or 2 patients of, suppose you have prescribed in 10, 15 patients, 1 or 2 may say that little bit of stinging is there, but remaining 10, 12 patients will not say that there is stinging. So I personally prefer that only. I haven't done, honestly speaking, I haven't done a comparative study between these two, so I'm not in a position, and I don't think there's any literature which has compared. So it will not be advisable to comment on that, but personally, I prefer that international company also, and I know that the company, the products are good, so, and since the stinging is less, and even the Indian companies that are manufacturing, they are quite reputed companies. So I don't doubt their integrity and credibility. The only difference what I feel is that the stinging is quite significantly less in that product, international product, multinational product, well, in comparison to our own company's product. Yes, it should be. Actually, antibiotics should be given whenever you have done any intervention. No, so it's always better to use antibiotics. So, but it should be given only for basically the idea is for prophylaxis. So 3 times a day is good enough. Actually, madam, amniotic membrane should always be used after completing that incubation period. So, fresh amniotic membrane, use of fresh amniotic membrane is not advisable because of the risk of transmission of disease and all that. So, we should always wait for that incubation period of 90 days, and then only it should be used. So, it is normally preserved in minus 89 degrees, and we do it at our center only. You can use it fresh. There are people who do use fresh, but theoretically or even practically, there is some risk of that incubation period of that. Serology. If suppose after a month, the serology of that the female from whom the amniotic membrane has been taken becomes positive, then you will feel very, very miserable. That's the thing. Madam, if you are using cyclosporin, use it at least for 2 years in VKCs. Yeah, because there are 2 things. One is that it controls inflammation and it improves the ocular surface by improving goblet cell density, by improving the tear function. So you should use it on a long-term basis. So if the patient becomes absolutely asymptomatic, then there are 2 things that can be used. One is lubricant and the other one is cyclosporin. And maybe for 1.5 or 2, depending upon the severity. If the patient became asymptomatic, there is no papillae, even at 6 months period, then maybe you can use it for 1 year and then stop and continue on lubricant. Never stop lubricant before the age of 14 or 15 years, because the lubricant helps not only for improving the surface, keeping the surface moist, but also washes off the antigen. So that risk is always there. And there is a risk of, the word I said vernal is misnomer, but it is partly misnomer. It is not totally misnomer, because there is always an exacerbation during the season. Okay, so during the season, if the patient is asymptomatic, then you continue on cyclosporin and lubricant. But during the season, you may start once a day loteprednol. Olopatadine can be stopped once the patient is absolutely asymptomatic. The reason is this, that olopatadine per se causes dryness. It causes dry eye. So it is advisable not to use it on a long-term basis, rather than if the patient is totally asymptomatic, 8 years, 10 years, 11 years of age, 8 years, 10 years, 11 years of age, then in that case, lubricant with cyclosporin is quite effective. Stop olopatadine, because the risk of dry eye, occurrence of dry eye is there with olopatadine. Now, if AMJ is not possible, then in that case, if there is an ulcer as such, then you just treat the allergic conjunctivitis. Intensive lubrication should be given. That is something which one can do. Sorry? No, scraping should be done only if there is a plaque. It is not seen in all the cases. So if there is a plaque has to be removed, otherwise healing will be an issue. So remove the plaque, and then intensive lubrication can be given if amniotic membrane is not possible.
I think
One more
rest
question,
of
sir.
the
Last question.
Okay.
Olopatadine and sodium chromoglycate. What works better?
Both work well,
There have been like.
but
yeah.
olopatadine has of late olopatadine has been shown to be better in the sense that it is dual acting, and the number of drops are lesser, so the compliance of the child is better. So olopatadine, I mean, of late we have been using olopatadine only, but earlier when we were using sodium chromoglycate, the response was still good with that also. The only advantage is that here you don't have to use any antihistaminic.
Right.
So the compliance becomes better. Then the child uses the other drops like cyclosporin or lubricant. The chances of those drops being used is also better. So the response will be better. So it has an additive effect rather than, I'm not aware that there's any comparative study done between olopatadine and chromoglycate. If that there is.
And one more question. So I've seen few doctors practicing like they're prescribing oral low-dose steroids in severe cases of VKC. Your take on that? Like 5 mg Visolone for like couple of months or 3 months. So you have any experience with that? Or came across?
I personally don't give oral steroid for these things, for these chronic allergies, because for these you have to use it on a long term. Now, if the child is very much symptomatic, in that case, I may give fexofenadine tablet, like Allegra, systemic tablet for maybe a couple of weeks. I have not used systemic steroid for VKCs because I don't see any reason for doing it.
or maybe the systemic immunosuppression in the severe cases when you have a
See, it is a surface inflammation, and whatever immunosuppression or immunomodulation you have to do, you can't do it by means of local injection by steroid. You can give tacrolimus, which nighttime tacrolimus will stay for 12 hours. So use of immunosuppressive systemic for VKCs will be an overdose of medication. This is what I feel.
Okay. Thank you, sir. Thank you. And now I will request Dr. Mayank Mahajan to take his talk on the interesting case scenarios. And thank you, Rajesh Sinha, sir, for we have taken you a lot of time on.
So good morning once again, and thank you, Dr. Sonal, for inviting me to this course to give this talk. So this will be like discussion of various experiences or cases which probably were misdiagnosed or overdiagnosed during a clinical examination. So probably this talk also reminds me when I took ophthalmology, I was like, okay, ophthalmology, eye is there, I'll like just finish it like anything. Nothing is there. Once I entered into ophthalmology, and then I was like, the depth of ophthalmology is so much, you cannot kind of, confine it. The same way, starting with conjunctivitis, we came across eye flu. From our school time, eye flu. Then how this conjunctivitis at times poses challenge. So we'll be coming across some of the case scenarios which may be very simple and sometimes very atypical. So coming to our first case, which was of a 29-year-old female who presented with discomfort, pain, redness, discharge, went to a very famous local ophthalmologist, examined there, and was diagnosed as viral conjunctivitis, and advised topical lubricant eye drops, oral non-steroidal anti-inflammatory drugs, asked to come after 1 week. So the patient was not kind of relieved with the symptoms, went for another consult to another doctor. The doctor saw the prescription, made another diagnosis, added an antibiotic, and diagnosed as bacterial conjunctivitis, so the same treatment along with added topical antibiotic. Patient again not relieved, come back for a third consult. Third consult, what it was a case of anterior uveitis, which was not properly examined. So I took 5 minutes from the patient, spoke to that patient, what actually happened on the first visit. The first visit, patient was not examined on this slit lamp. Seen, asked for symptoms, and at times you see the patients are also, they feel like you ask, there is pain? Yes, pain is there. Discomfort? Yes. Redness? Yes. Discharge? Patient feels the more I tell, the better I get treated. So that was the thing. The first visit, he was not examined on the slit lamp. The second visit, the doctor took the prescription rather than examining the patient first on the slit lamp. That is also one of the mistakes which is commonly done, and especially for the young ophthalmologists who are there. First, do your own examination, then see the previous or prescriptions or medicines. So the patient was managed, was a fairly simple case, but went through 3 consultations, just a first episode of anterior uveitis. So coming to the second case, so this was a 24-year-old male student, which was a hostel inmate, presented with discomfort, redness, itching, and on examination of the lashes, you see these cylindrical deposits, which appeared to be like blepharitis, but on course examination, you see they are cylindrical egg-like deposits. Some of them are hatched, you see holes over here, and some of them are intact. So now these are those cases which you not commonly see. So then I went through a kind of Google search in the clinic itself and resembled it like a case of nits. Then I started looking for the culprits. So culprits in this nits is the crab louse. So I'll just play a video here. So there you see, at the base of the lid margin, nicely seated is the crab louse. So this was a video which was made on the slit lamp with my cell phone itself. And the eggs are there. So this patient had constant complaint of itching, irritation, and was treated with lubricants and antibiotics. I'm trying to remove this louse manually. And see how tenaciously they are holding the lash. The entire lids come down, and the louse still it's holding the lash. So mechanically, I removed all these louse from the lid margins as well as the eggs. And diagnosis was obviously Theriasis palpebrarum Pharyngoconjunctivitis. The management has what it was available at to my local nearby pharmacy shop. I did mechanical removal, petroleum jelly, permethrin shampoo, advised the importance of personal hygiene, and gave us to consult a dermatologist. So a little bit of discussion about this. So 3 types of louse are there in the body louse, head louse, and the pubic louse. And strangely, the louse which are closer to the eye, they do not infect the lashes. It is the pubic louse which actually infects commonly the lashes. So Theriasis palpebrarum is uncommon cause of blepharoconjunctivitis and is easily misdiagnosed. There are other variable management options. So whatever is available at your local pharmacy or nearby shops, you can opt for that. So none of them are 100% ovicidal. So manual removal of these nits and louse and along with any of those ovicidal agents is recommended. So coming to the third case. The third case was a 27-year-old male who had redness, discharge, foreign body sensation, irritation, and excessive discomfort in the morning. Now again, examining on the lid margins, you see at the margins, the cylindrical dandruff-like deposits at the lash bases, eyelash base. So a bit magnified, you see this again. These are unusual presentations, and this was a case which was diagnosed as Demodex blepharitis. So management again was done with tea tree oil, soap, and shampoo, lid scrub with 50% tea tree oil, lid massage with 5% tea tree oil, lid hygiene, and again a dermatologist's opinion. These are the cases which don't respond to conventional treatment, and then they indicate you to look for something else. So importance of examining the adnexa is very important in these cases. Now coming to discussion of this, these are the smallest arthropods with which is Demodex follicularum and Demodex brevis. 2 species are there. Follicularum, as the name suggests, is attached to the follicle, a lash follicle, and is 0.3 to 0.4 mm in length, and the brevis burrows inside the pilosebaceous unit in the sebaceous and meibomian glands, is 0.15 to 0.2 mm in length. Infestation is high in 20 to 30 years of age group when the sebum secretion rate is at its highest. So this is the diagram where you see Demodex follicularum, which is attached to nearby to the follicles, and these are the brevis which burrow inside and these are also causes of meibomian gland dysfunction. So again, a follicle attached with this demodex follicularum, hair follicle seen under a microscope. So again, what is the confirmatory? Confirmatory microscopic examination is also one of the confirmatory tests. These mites are normally also present on the human skin, but when pathological infestation takes place, when their quantity increases, when they kind of multiply too much in excess. So high index of suspicion is there when blepharitis, conjunctivitis, or blepharoconjunctivitis in adult or recurrent chalazion in young patients and refractory to conventional treatments. So when there is madrosis or recurrent trichosis, you have to think of these things. Coming to the fourth case. This was a 48-year-old female who presented with discomfort, redness, discharge, both eyes, burning sensation, foreign body sensation. So I everted the lid margin. You see upper tarsal conjunctiva, which was red, velvety, and inflamed. And there a diagnosis of superior limbic conjunctivitis was made. You see this aspect also, the superior conjunctiva was more congested. So etiology, again, superior limbic conjunctivitis, keratoconjunctivitis, secondary to superior bulbar conjunctival laxity, which induces inflammatory changes from mechanical soft tissue microtrauma. Other risk factors can be prolonged eyelid closure with associated hypoxia or reduced tear volume, and also to, at times, functional changes in conjunctival apposition to the globe following upper eyelid procedures. Again, it's more common in females, and symptoms may remit and exacerbate, may be variable in degree. And patients with corneal, at times corneal filaments are very, very symptomatic, and they distract you from examination. SLK may be associated with thyroid dysfunction, keratoconjunctivitis sicca, and rheumatoid arthritis. Management, there are various management options like patching, BCL, topical vitamin A, even topical cyclosporin drops, mast cell stabilizers, tacrolimus ointments, autologous serum drops, but the best treatment is surgical resection of the redundant bulbar conjunctiva. Now coming to a final case, which says, as the name suggests, to do or not to do and when to do. So this is a 22-year-old male who came for opinion about LASIK and had a few haziness and history of red eye month back. This was the presentation. 1 month back, wanted to come for LASIK opinion. So you might be getting patients like these for cataract surgery or refractive surgery. And then the dilemma comes, what to do? So I asked this patient, who was a patient for refractive surgery, I asked, defer the surgery, put him on topical steroids. Now, putting on topical steroids increases the infective period. So coupled with povidone iodine, so that infectivity decreases, asked him to come back after a couple of months. So I use generally low-dose topical steroid. And then this was the case. Now, there are other agents also for them. So refractive surgery in these kinds of cases, if they clear also, the antigen is still lying there. And per se, clearance of these infiltrates doesn't kind of ensure you that this won't recur. This can recur, as told by Randall-Ben et al. This was a case which was reported in 2004. Even after like clearing, this recurred. So it won't ensure you that these infiltrates won't recur in the future. So that you have to take a call, you have to wait, probably you can wait for the recurrence. There is no specific timeline for how long you have to wait. And if you take a same scenario of a cataract surgery, I feel like after waiting for some time, you can go ahead with the cataract. After cataract, again, you will put steroid drops. That will take care.
Actually, just I wanted to, okay, that is your...
So finally, take-home message is the conjunctiva is just a mucous membrane which gives signs for ocular pathologies which may be underlying, overlying, or lying within. Hence, its infection or injection always indicates a thorough ocular examination.
Can we just go to the last slide so that we can have some discussion? This is a condition wherein we, very often we get such a case. It's an adenoviral keratoconjunctivitis. And now what Dr. Mango was saying that yes, recurrence can happen. Now, the point is that if you have such a scenario, typical nummular subepithelial multiple coin-shaped haze, this is a typical adenoviral keratoconjunctivitis. Now, if it is in the center of the cornea, you have to use steroid, otherwise it will not clear up. And if you wait for a period for it to clear itself, sometimes you will have a permanent spot there in the center, and that will affect the vision quantitatively and qualitatively definitely, and quantitatively also. So we have to use steroid in these cases, but if we use steroid, the risk of recurrence also increases. So any opinion, anything you would like to suggest?
we can have an open discussion
Yeah.
regarding this.
Can
It's
we,
a very common scenario. Which
Yeah, Dr. Supriyo. Yeah. Uh-huh. Uh-huh. Mhm. 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 Okay. Okay.
6, 18, 6, 12 like that. And only the patient is the patient is 6, 6.
That is one way, that is one method of, taking care of the recurrence, like you use a low potency steroid, very gradual tapering and, using it at intervals. There can be some other, yes sir, your approach. Okay. Okay. Okay.
So, sir,
But
do
sir,
you
we
also
come to
prefer,
the pathophysiology of this thing. See, these are antigens,
yeah, so I
and
think
it is a reaction towards the viral antigens,
immunological reaction. So,
immunological reaction. So,
Actually, it's a
Okay.
combination therapy that works. Otherwise, if you feel, then azithromycin or these things may not have a direct effect on role in these. We can have some different approach also. Dr.
Sir,
Sonal would like to say something.
like what the recently shown the povidone iodine. What's your view on these povidone iodine eye drops?
For in these cases, again, these are like antibiotics. Now,
Okay,
these are
that's- okay,
antivirals.
so
So,
in these cases, I
yeah.
think cyclosporin or
Povidone
the
iodine,
yes,
will-
that is
will-
what I will agree with her, that cyclosporin drops, they are quite useful in these cases. When we start steroid along with cyclosporin, then you can stop steroid, because steroid has its own problem. That's why Dr. Supriya was mentioning that you have to give it, once in 3 days, once in 4 days. So, I mean, that can be one approach, but there's a tendency for the patient to forget also whether you have completed 15 days or not. So, I mean, that is one way of thinking. But the other thing is that, if we use cyclosporin, which is a very good drug, in these cases, in combination with steroid, that's very useful. I personally use cyclosporin along with steroid in these cases, taper the steroid and taper it off for a period of nearly 8 to 10 weeks, so that by that time cyclosporin has taken over and started working. And once it has taken over, started working, continue with cyclosporin for 6 months to 1 year, so that the risk of recurrence decreases, and cyclosporin doesn't have any local or systemic complication with that concentration.
What my approach is, I start with the 4 times cyclosporin and
Okay.
with the steroid, and then slowly shift it
Okay.
to a twice a day. So, what's your approach, like using it the same dosing or?
I mean, see, technically, it's difficult to say that 4 times a day initial loading dose followed by twice a day has a better role, or twice a day given throughout is a better role, because there's no such
Guidelines.
comparative study. I personally use twice a day cyclosporin, and I use it for 6 months to 1 year. Topical steroid for these cases very essential, because you want to clear the central cornea. Patient has come to you for vision, quality and quantity of vision. So topical steroid is essential for clearance, but the recurrence is increased by use of steroid. So for that, low potency immunomodulator like cyclosporin used for 6 months to 1 year takes care. So steroid with cyclosporin are combined, and then later on taper off the steroid, continue with cyclosporin. Antiviral, many people use acyclovir. Technically there is no role. We may have a feel-good factor by use of acyclovir. That's the only thing. Otherwise, as such, there is no role.
Even it can, I think it induces the epithelial toxicity.
Yeah, absolutely. Agree with you.
so these lesions
Sir.
actually appeared very fresh.
Yeah.
But at times we come across very faded lesions.
Yeah, yeah.
In that again, it is a challenge like to do or not to do.
Yeah.
Very faded,
Yeah.
where you feel like, okay, this might be 4 months, 5 months back, something. This is very fresh.
Yeah, that's a very important one that we also want to discuss with the audience and the sir also, that if suppose we want to do a cataract surgery or some refractive surgery, so how long we should wait before operating them? Is there anything?
As such, I would say that in such cases, we should wait for at least 6 months before doing any surgery. Yeah, 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 yeah. There is no definite guideline for that. There's no definite guideline for that, but we should wait for long because risk of recurrence is there in spite of whatever drugs you are using. So you wait for a safe period and then go ahead with the surgery.
So as far as the cataract surgery is concerned, and if it is kind of urgently or maybe required soon, so if you feel the keratometry is coming correct, then you
Yeah.
can go ahead. So that is one of the important things, because you can see the Myers and everything. If they are correct, they are precise. You can compare if one eye is there or both eyes also. So, and then you can take a call on the cataract surgery.
Yeah, you can go a little earlier
Yeah.
than that if you feel that the cataract is so advanced that the patient is having problems. So you can go ahead and do the cataract surgery.
But I think take-home message should be we should avoid use of antibacterial and the antiviral like acyclovir in these cases, because it has been proven they have no role.
Thank you. Thank you so much.
Okay, so with this we'll close this session, and we are really thankful to our audience and our and my co-instructor for making this session really a great success. Thank you all.